Hey guys, welcome back to it. Today we're going to be discussing pain. What is pain? Pain is kind of a funky symptom, and there are a couple different types. Clinical pain is going to be any pain requiring medical treatment. It impacts about 1.5 billion people more 1.5 billion people worldwide, which is more than heart disease, cancer, and diabetes combined, and cost society about $500 million annually, which is equal to about $2,000 per American. Women tend to be impacted more so than men, and the experience of pain is more commonly associated with increased age. And the most common reason that people will seek medical attention is pain. And so for this reason, it's considered to be the fifth vital sign. So pain's kind of funky in that way, in that it's this tremendously common experience. And as we'll establish on the next slide, it's interesting in that it's very subjective in nature. It's not something that we can tangibly or objectively measure, like heart rate or blood pressure or respiration rate or body temperature, which are the other four vital signs. It's something that is very subjective. But again, because it's so common, it ends up being a prime concern and again is considered to be a vital sign. Acute pain is sharp or stinging that is short-lived and typically related to tissue damage, which is a fancy way of saying injury. Recurrent pain is alternating periods of pain and no pain that persist for at least 3 months. So this doesn't mean like, oh, I hurt myself and I was in pain and now I'm not in pain. It means for at least 3 months you're alternating between pain and no pain. So examples include migraines or chest pain, these experiences that kind of come and go. Chronic pain is more dull. It can sometimes even be described as a low-grade kind of burning sensation, and it lasts for obviously a long period of time. Clinically, we are looking for at least 6 months. Hyperalgia may be a term used to describe a person who becomes more sensitive to pain over time. So that term means more pain, again, describing that increased sensitivity. The most common way that we assess or measure pain is the Wong-Baker FACES pain rating scale, which subjectively breaks pain down onto a 1 to 10 scale, from no pain to the worst possible pain, and uses FACES to kind of anchor or quantify various numbers and help patients to direct their experience to a particular number. So that's going to be the most common way that we measure pain. As I mentioned before, there are no objective measures of pain, only subjective ones. So we ask people to tell us how much pain they're in versus being able to measure it in some way or another. This isn't for a lack of trying. One of the approaches that came close was using EMG, using this as a way to measure muscle tension, thinking that if we could measure like how tense a person's jaw or shoulders were, like maybe that would be a way to infer how much pain a person's in. But at the end of the day, it didn't really prove to be a reliable measure of pain. Behavioral measures may also be used as signs of pain. So we can ask relatives or friends or family, what have you noticed that, indicates that this person is in pain. You can look for target behaviors potentially in an appointment, like someone grimacing, expressing verbal complaints of pain, sitting in an awkward posture, not really being able to move around. Those are all indicators of pain. With kids, you might look for emotional responses to pain, like crying or fear of needles. And again, these can be apparent in an appointment session, or these may be things that you're asking loved ones about. But at the end of the day, self-report measures, again, are the most common solution to this problem of how to measure pain. They're also a very simple solution where we will, again, most commonly ask a person to tell us on a scale of 1 to 10 how they're feeling, but there are also longer questionnaires that we may use asking a person to quantify their discomfort. So in terms of exploring pain a bit more, we're going to start off by exploring the physiology of pain. So what is happening in our bodies that contributes to us feeling pain. This is important for everybody to understand, regardless of whether you're more a physical or a mental health person, because it can be helpful to explain pain to patients and help them understand what they are going through. At the end of the day, I've really made an effort to boil this down, so hopefully this won't be too overwhelming for those of you who don't really identify anatomy or physiology as your strengths. But again, it is important to just kind of know some basics in terms of what's happening with the pain experience. First thing to recognize is that not all pain is triggered by one type of stimulus, and more specifically, that injury is not necessary for pain. So sometimes we feel pain because we fall and physically hurt ourselves. Other times we feel pain for emotional reasons, or sometimes in the case of like a chronic pain or fibromyalgia, pain might just feel relatively random and there might not really be an injury to point to specifically. Ultimately, when an injury does happen, which is the most common way that people will experience pain, what happens is that a sensory receptor at the site of injury converts a trigger, i.e. the injury itself, into neural impulses, and this is what generates the sensation of pain. One thing that you'll realize as we work through the physiology of pain is that while pain is something that may be associated with a physical injury, that ultimately pain is a neurological sensation. So it's really only something that we feel when that neural impulse gets all the way to the brain. And so in some cases, the brain is telling us that we feel pain even when we haven't been injured. And so this can explain pain in cases of like chronic pain or fibromyalgia, or in other instances, sometimes the message isn't getting all the way to the brain effectively. And so injury is present, but the brain's not registering pain, and so the person's not registering pain. But in typical situations where there is injury, an injury occurs, which triggers a series of neural impulses, which communicates the message of pain to the brain. There are several different candidates for the primary pain receptor, but the primary candidate, i.e. the culprit that is responsible for initiating the series of dominoes to communicate the message of pain to the brain, is going to be a group of receptors called free nerve endings. These are receptors that are found throughout the body that respond to temperature changes. So you feel pain if you are touching something hot or something cold. Pressure changes. So you might feel pain if someone is kind of like squeezing your hand or another part of your body really hard. They haven't broken the skin or physically injured you, but that pressure change is there. And chemical change. So if you have been injured or cut, chemical changes happen at that point, which result in the message being communicated to your brain. Similarly, chemicals are secreted by internally damaged tissue. So even if the skin isn't broken and you've been like punched or something like that, which has contributed to subdermal damage and something like a bruise, there still is that damage beneath the surface, which is still causing chemical change, which is still initiating this message to be communicated by the free nerve endings. And so FNEs are responsible for all types of injury-related pain in this way. This information is ultimately relayed to the brain, where it is registered and interpreted as pain. And so for this reason, free nerve endings that are activated by noxious or painful stimuli are oftentimes referred to as nociceptors, meaning receptors activated by pain. The next step after the nociceptors or the FNEs is that the information continues to the central nervous system via either fast or slow nerve fibers. Fast nerve fibers are large and myelinated, meaning they are covered in cholesterol. So you might remember the term myelination from our discussion of diet and obesity. And that one of the good things that comes from cholesterol, one of the reasons that our bodies create cholesterol from dietary fats, is that our bodies need myelin. And again, myelin is this cholesterol that goes around nerve fibers to help them communicate messages more quickly. more specifically, myelinated nerve fibers communicate at a rate of about 200 miles per hour compared to about 2 miles an hour for unmyelinated nerve fibers. So fast nerve fibers, they're large, they're myelinated. They serve the skin and mucous membranes of the body. So this skin, obviously, but then mucous membranes would include things like the inside of your nostrils, for instance. Pain that reaches the brain via the fast nerve fibers is perceived as stinging and localized. So it's this acute, sharp, intense experience, and it's localized to the area of the injury. And it's generally stimulated by intense pressure or extreme temperatures. So touching something hot or cold, intense pressure in the form of an injury, that type of thing. Slow nerve fibers are smaller and they're unmyelinated. They serve all body tissues except the brain itself. So these also serve like organ systems. So if you're sensing like more internal types of pain, which can be duller sometimes, we're going to be sensing this information via slow nerve fibers. This information is typically perceived as dull, aching, or generalized, and these fibers are typically stimulated by chemical changes in damaged tissue. So for instance, you might feel the fast nerve fiber, that kind of stinging, intense pain when you are immediately injured, but then you may feel more kind of that dull, aching following injury when the injury is now a bruise or it's healing, and maybe it hurts when you push on it because you're kind of triggering those chemical changes released by the damaged tissue. The example I always give of this is a bee sting. The reason that I use a bee sting is because one day I was teaching this, and then on my way home from work, a bee flew in my car and stung me while I was driving. And one of the funny things about teaching or even doing therapy I found is that I will sometimes experience things, and the first thing that will come to my mind is like, man, this would be a really good example to use in class, or like, oh, like this really relates to this therapeutic condition that I'm working with. And so the first thing I thought when I'm on the side of the road trying to get this bee out of my car is that, wow, like I'm experiencing the sting right now via my fast nerve fibers. And later, when this pain becomes duller, it's going to be my slow nerve fibers. And I just couldn't really help but laugh to myself because I was in pain, but I had just taught this class. And of course, I'm thinking about like health psychology randomly on the side of the road. So now I use bees as an example. So hopefully that will help you cement the difference between these two. So following the FNEs and then the fast or slow nerve fibers, the information then enters the sensory tracts of the brain, which funnel the information further to additional brain areas. Information which includes not only that pain has been triggered, but also information about like where the pain is originating, how much pain is this in relation to a movement, like did you just kick something or stub your toe? All this information enters into a brain region called the thalamus, which is the brain sensory switchboard, before being routed to the somatosensory cortex of the brain, which is the area of the brain that receives information relating to touch and feel. The reticular information is also activated along the way by fast nerve fibers, and the reticular formation is a part of the brain that's responsible for arousal and alertness. So this makes sense because fast nerve fibers are communicating information most typically about immediate injury. So like if your hand's on a hot plate, it makes sense that your reticular formation also be activated so that you are hyper alert to the situation and you can immediately kind of pull your hand back. Slow nerve fibers ultimately trigger the hypothalamus and the amygdala. And these are going to be areas of the brain that are more commonly associated with like memory and emotion and just more kind of instinct, which makes sense because there might be more of like an emotional level in terms of processing past injury. Visceral or internal pain is frequently experienced via referred pain, meaning that the pain is kind of referred to and experienced in another area. The example that I always give of this is like the left arm pain that males more so than females will typically experience during a heart attack. The reason for this is that the heart itself doesn't have a lot of pain receptors. And so because of that, in order for that message to kind of get to the brain, it ends up being referred in a way. So it's kind of like the left arm is communicating the message to the brain that the heart is unable to communicate itself because of its lack of receptors. And so because organs in general have fewer receptors than our skin and our external structures, because you're less likely to be injured internally without also being injured externally. Frequently, the pain ends up being referred to an area where you have more sensory receptors and the message can be communicated more strongly. So again, the heart attack is the example I always give of that one. As far as what chemicals are involved in pain, there are a couple of different ones. Substance P and glutamate are continuously stimulated by injured nerve endings, which increase pain messages. So these are the chemical changes that kind of contribute to that element of pain when an injury is present. Enkephalins, which are our body's natural opiates, deaden pain sensations. These chemicals are activated by the periaqueductal gray area of the brain, which reduce pain immediately. The PAG is the primary site that morphine and other drugs also has an effect on. So in a nutshell, this is a chemical, it's a natural opiate. We've covered opiates already in this class, so you guys know that those are pain relievers and it deadens pain sensations. And it's activated by an area of the brain that's responsible for reducing pain. And again, this is an area of the brain that other drugs, similar drugs, have an effect on as well. Endorphins also help to relieve pain, and you guys know that these are actually increased by stress. If you guys think way back to chapter 4 and our added reading about zebras, you guys will remember that one of the things that happens when we're stressed is that the experience of pain decreases, and a lot of this has to do with like the adaptive evolutionary example of like a zebra or another more primitive vertebrate who is injured, and it doesn't make sense to feel pain right now because you've got to get away from the predator. And some of you guys might even identify with that, like maybe you remember playing soccer or something like that when you were younger, and like you walk off the field at the end of the game and you're like, oh man, like I'm bruised or I'm scratched and I'm bleeding, and you didn't even really realize it. It's because through that stress, your endorphins were deadening your pain experience, and the PAG, the periaqueductal gray area, is involved in this as well. Finally, something called the anterior cingulate cortex, or the ACC, also plays a role in modulating pain. So in this way, the brain is almost capable of turning off pain, and this area may be deficient in chronic pain patients. So this might be one of the reasons that chronic pain patients experience chronic pain and why pain persists beyond injury. So this is kind of an interesting brain region, and that, again, it kind of indicates that the brain may be able to selectively attend to pain and then not attend to pain, contributing to us kind of ignoring or not feeling pain when our brain is not focusing on it. There are several genes that also contribute to our experience of pain, and that genes can be responsible for several chronic pain conditions. One of which is something called chronic insensitivity to pain with anhidrosis, or CIPA. You guys can watch this video. There's a link to it as well in the syllabus and on As You Learn. This is a really fascinating diagnosis, in that this is someone who cannot feel pain. So pain is absent. And in this video, you'll see a little girl who grows up with CIPA, and you'll see that she gets injured a lot when she's little. Because when you think about it, pain is a really helpful piece of information. It tells us things like, hey, you shouldn't do this. This is threatening your survival. And so without that feedback, it's really difficult to learn the things that are potentially threatening to you because you don't have that natural feedback loop. And so SEPA is a really good example of this idea of pain originating from the brain. Because I mean, as you'll see in this video, this little girl goes through some really painful injuries, but just doesn't feel it. So the injury is there, but at the end of the day, that information is not getting to her brain. And so she's not feeling the pain, because ultimately pain, while related to physical injury, is ultimately a brain-derived sensation. Genes can also contribute to more chronic experiences of pain, things like fibromyalgia, which we'll talk about a little bit later on. One additional kind of theory that I want to introduce while we're still kind of on the topic of physiology before kind of moving forward is the gate control theory of pain. This is an older theory of pain that originated with Melzack and Wall in the mid-1960s. They proposed that pain is not a straightforward experience that goes from the nerve endings to the brain, so it's not like this series of dominoes. Instead, they proposed that the pain must surpass a threshold in order to trigger pain. So something like a pinprick or something really small might not surpass a pain threshold, and so that information would be kind of selected out and wouldn't get all the way to the brain. So in this way, they believe that there was like a gatekeeper in the spinal cord or the brainstem that decided, so to speak, what pain got through and what pain using a threshold as kind of a marker. They propose more specifically that the substantia gelatinosa, which you do not need to know that specific word, but it is a structure within the spinal cord, and they believe that that was the structure responsible for this gatekeeper type of role, and that the brain could open or close gates. So they believe that that anterior cingulate cortex that we talked about earlier could play a further role, that this gatekeeper constantly was kind of sorting out various pains, not letting smaller subthreshold pains through, but that the brain could also kind of intentionally block out or ignore pain. For instance, when you are stressed, and endorphins are playing a role in dampening pain. While it is still acknowledged today that things like endorphins can dampen the pain experience, and that there are regions of the brain that seem to be able to selectively attend to pain or ignore it, this idea of there being this like master gatekeeper in the spinal cord has been somewhat debunked, or it's definitely not as clean as Melzack and Wall presented it in the 60s. And today, the dominant theory of pain is, of course, a biopsychosocial one, meaning that pain is a combination of biology, which we've extensively discussed thus far, but then, of course, that there are also psychosocial elements to pain as well, which we will discuss throughout the class. So at the end of the day, what is phantom limb pain, and how does it factor in to what we've already discussed? Phantom limb pain is pain that is perceived to originate from an amputated limb. So a limb was there and now it's not, but it still feels like your foot is hurting again, even though your foot is no longer there. The answer to why this problem exists really goes back to this idea of pain comes from the brain. And so you've got to kind of wrap your mind around that idea in order to understand phantom limb pain. More specifically, what's happening in the brain is that we have these two cortices, these two regions in the brain. One is the primary motor cortex, the other is the primary somatosensory cortex. The motor cortex is the area of the brain that is responsible for movement. And specifically, we understand very specifically what areas of the brain do what. So we understand that like this particular ridge of the brain is responsible for moving the tongue, and this particular ridge of the brain is responsible for the thumb, and this is responsible for the knee, and so on and so forth. And similarly, the somatosensory cortex is responsible for perceiving touch based sensation from the various parts of the body. So again, we know this part of the brain is responsible for receiving information from the lips, and this part from the hand, and this part from the neck. and so on and so forth. And so even though the limb has been removed, in this case, let's use a leg as an example, the leg has been removed, those areas of the brain still exist. So there still is an area of the brain that is dedicated to moving that part of the body that's not there. And there still is that area of the brain that's responsible for feeling sensation from that part of the body that's not there. And so one of the things that can happen sometimes with phantom limb is that a nearby area of the brain will be stimulated, and that will kind of bleed over into the affected area of the brain that is related to this amputated limb. So a related example that I always give that seems to help students kind of cement this idea of different areas of the brain being related and there being kind of the spillover effect is the idea of the toe curling orgasm. Sounds unrelated, but if you look at this graphic of the brain, you'll see that the areas of the brain that are responsible for both moving and sensing the toes and the genitals are right next to each other. So there's actually a reason for toe curling orgasms. It is that your genitals are being so strongly stimulated that that information is spilling over into the nearby region of the brain, which can contribute to movement, curling of that area. So again, seems unrelated, but if you can wrap your mind around that, to a degree, that's kind of what's happening with phantom limb. It's that a nearby area of the brain is being stimulated and it's kind of spilling over and feeling like that old sensation where that, again, that limb is currently amputated. Basically, treatment entails retraining the brain, and this video that I have for you here briefly shows a version of treatment that includes mirrors as a way to rewire the brain. Factors that influence pain include things like age, which we already talked about. So that's going to be more of a biological piece, obviously. Specifically, headaches, facial pain, and abdominal pain seem to increase with age. Women tend to experience more migraines, tension headaches, pelvic pain, facial pain, and lower back pain than men. Women also receive 5 to 10% more prescription drugs for common complaints than men do as well. People of a lower SES tend to experience more musculoskeletal pain, pain intensity, and disability. Something psychosocial, though, is that the meaning of pain may impact the experience of pain. So people tend to be better able to experience and tolerate pain in instances that carry meaning. So childbirth, tattoos, recovering from a meaningful surgery, exercise and feeling sore the next day. These are all experiences that are painful, but that carry meaning, and people tend to be able to handle that pain easier because of that feeling, or in some cases even feel the pain less because of the meaning that's being attached. There also is such a thing as a pain-prone personality. Folks who are anxious, worried, fearful, and depressed are more likely to report pain relative to others. So we've got some reiterations of some biological pieces in here, but then we also have some psychological pieces as far as meaning and personality go, and then also some social pieces in terms of the environment of poverty potentially playing a role in the pain experience as well. In terms of treating pain, opioid analgesics act on the spinal cord and brain to reduce the intensity of pain messages. And again, you can flip back a couple slides if you need to remind yourself of the areas of the brain that are involved in that reaction. These pain medications are highly addictive, as you guys know now that we've covered opioids previously in the semester. One of the things that's happened recently is physicians just becoming scared to prescribe these things. And so under medication can be a problem. And what I mean by that is that opioids aren't a thing to just kind of completely not use. They're a medication to use selectively, and they definitely should not be used to the extent that they have been used, which has contributed to the opioid epidemic in the United States. But there's certainly situations where they should be used, like if you break your femur or something like that. So it is important to know when to use them. So education in the area of pain and medication is definitely needed in medical education versus just kind of completely avoiding the situation. Non-opioid analgesics or NSAIDs can reduce pain, but they do so without sedation and the risk of addiction. But again, because they're weaker in nature, they can be appropriate for certain things, but there are definitely injuries and situations where opioids should really be considered. It's just a matter of really monitoring patients and talking to patients and kind of keeping lines of communication open. Surgery is not helpful, which may seem obvious or not, depending on, your experience with pain or maybe how much you've thought about this. But it's kind of interesting in that surgery is kind of an approach for pretty much every other physiological thing that goes on. Surgery is an approach for heart diseases. It's an approach for cancer. It's one of the big things that we've talked about in reviewing some of the medical conditions in this class as far as treatment options go. But surgery is not a helpful approach for pain. Like if you're feeling pain, in your arm, like going in and dealing with it surgically is not the approach. Things may be different if you're dealing with something like appendicitis, where there is something that needs to be removed, and that's kind of the site of pain. But for the most part, coming in with like chronic pain, fibromyalgia, surgery is not going to be helpful. There's a couple different other things we can kind of do beyond medication, which is definitely the route you want to take if what we're dealing with is more chronic pain. Again, pain medication, non-opioid or opioid, should really only be used for more acute pain. We don't want to use those things chronically. One potential approach to treating pain is something called counter irritation, which reduces pain in one area by stimulating another. So I kind of do this to a degree sometimes when I get like bug bites, where you have bug bite obviously and it feels really itchy. A lot of people don't know that pain and itch are communicated along the same nerves, so those same free nerve endings. And so one way to make the itch go away is I'll sometimes like dig my nail into the bug bite a little bit, like not enough to break the skin or cause injury, but enough to cause some pain. And what that is it's counter irritation. My brain is now paying attention to the pain and is ignoring the itch in that area. So that's an example of counter irritation, where your brain can really only focus on one thing at a time. Obviously not a permanent solution, but that could be a potential solution to like an acute type of pain to just cause irritation in another area to give a person a mental break. Transcutaneous electrical nerve stimulation, or TENS, is an electrical impulse delivered to nerve endings, which causes numbness. That's one way to overcome variants of pain as well. Behavioral therapy is the approach that I take more commonly, obviously, in my role as a mental health professional. In general, you can take more of a cognitive behavioral approach or more of a mindfulness approach to pain. Cognitive behavioral approaches entail things like setting goals. So I might ask patients with pain experiences to tell me like what they want to accomplish in life or what's important. And to focus more on pursuing those things, particularly if their pain experience is chronic. So if it's chronic, it's not really going anywhere. Sometimes I'll try to help them focus more on like, okay, if this is how you're feeling, would you rather be feeling this way and doing what you want to do, or just kind of feeling this way and doing nothing? I may use cognitive approaches to help people reduce cognitive distortion. So a person may feel like, I'm in pain, I can't do anything, woe is me, like I'm so stupid, I caused this pain, this is going to ruin my whole life. And so when a person is thinking about pain in terms that aren't healthy, in terms that aren't accurate, I may engage in cognitive approaches to help them think more realistically about what's going on. So the problem with these distortions isn't necessarily that they are pessimistic in nature, but that they are an overreaction and that they are kind of getting to the point where they're unrealistic. So like yes, you're in pain, but are you really never going to be able to do anything ever again? Like, no, not unless you're choosing to do that. So cognitive therapy entails kind of talking through some of those thoughts and really examining how realistic various thoughts are. Cognitive distraction may be helpful, so helping a person focus on something else. Behavioral distraction can be helpful too, so doing or thinking something as a form of distraction. This could include guided imagery, so helping a person to imagine a place as a form of distraction, like think of a warm, relaxing environment. Or cognitive distraction could include a mental exercise, like count backwards by threes as a way to um, refocus when they're getting their blood drawn, and maybe they really don't like needles and getting their blood drawn. So let's count backwards by threes as a way to distract during that experience. Relaxation techniques can also help to decrease muscle tension, which can help diminish the experience of pain as well. ACT is a more mindfulness-based approach, which again is going to help people to ground themselves in the present, what's happening right now. Sometimes in the case of chronic pain experiences, acceptance may be a part of the puzzle, like accepting where a person is and maybe that unfortunately this pain isn't going away. And kind of like the goal setting, what we might be focusing on instead is allowing the pain to be there and focusing on what we want to do with our lives instead of letting the pain limit us. Okay, last topic that I want to touch on is chronic pain and fibromyalgia. Chronic pain is kind of an odd diagnosis. I'll direct you to this TED Talk by Elliot Crane, who is a pediatrician and an academic. He does a really nice job of discussing this topic, its causes, and its treatment. So I will let you guys learn more about chronic pain through that TED Talk. Chronic pain seems to be more localized in general, meaning that you might have chronic pain in one particular area of the body, like you guys will see in the patient in this video. Fibromyalgia, however, seems to be more widespread musculoskeletal pain, and in particular tends to impact tender points all over the body, as you guys can see in the graphic on the screen. It's also typically associated with fatigue, sleep, memory, and mood issues. It seems to be stress-induced, and that stress can be physical or psychological in nature. There's no one well-supported cure, although perhaps behavioral approaches, such as the ones described by Dr. Crane above, may be a new avenue of research. So again, I'd suggest pausing to watch that video here. All right, that is all that I have for you guys. So consider what questions you have, and we will talk more about this in person.